Hello, good morning, everyone. So I think
हमारी आवाज नहीं आ रही, आवाज आ रही है?
hello, are we audible to each other?
Yes, sir. Yes, sir.
Yes, sir. Your voice is audible, sir. Your video is
Video is not visible.
visible, sir.
It's all fine. I think it's 8 o'clock.
Yes, I think we'll start.
So let me take
Hello, Dr.
the.
Devari sir.
Good morning, everyone.
Namaskar.
Morning, sir.
Welcome to this NISGI 6-star. We have really stars sitting in front of us. And
हमारी
in
आवाज नहीं
fact,
आ रही. We are not hearing the sound. We are not getting the
Not-
audio.
not
The Ganesh
audible.
is talking, but we are not able to hear.
उनकी नहीं आ रही सर.
हैं?
उनकी नहीं आ
टीवी का
रही.
वॉल्यूम देखो जरा टीवी का वॉल्यूम
वॉल्यूम से पूरा है.
am I audible? Chinmay?
जी सर, आपकी आवाज आ रही है सर. दलजीत सर, आपकी आवाज भी आ रही है हमें सर.
गिरीश सर की नहीं आ रही थी, so I thought maybe from that side audio is an issue.
अभी आ रही है सर.
हाँ,
अभी-
अभी
थोड़ा सा दिल लगने में थोड़ा टाइम लगेगा.
आपकी दिल की आवाज आ रही थी सर.
अच्छा, chalo. Okay, fine. Good. So let me welcome everyone, and this is a new beginning, and especially the AIMS has also joined us, and led by Daljit. We have been doing exceedingly well for last 3 years, and more centers are getting associated with this. We want to be really worthy and effective. When more centers get associated, more science comes, more experience comes from different places. My only concern is that with more participation, let's our moderator do a wonderful job so that we do an effective output and appropriate time management. So with this, I wish everyone, and I see Dr. Derari sitting in front. Welcome, Dr. Derari. So all the very best. Please take over.
So shall we start with the prayer, please?
Yeah, please go ahead.
So I'll request everyone to please pray with me. Oh God, bless us
Oh God.
Bless us,
so that will not harm anyone.
so that we
We shall do good to others.
shall do good to others.
We shall try to learn at least one thing new in a day.
We shall try to learn at least
Try to
one
learn at least
day.
one new thing in a day.
We shall try to become a better communicator.
We should try to become a better communicator.
We shall try to become a good time manager.
We shall
We should
try
try
to become a
become a good time manager.
We shall be truthful to ourselves and to others.
we shall
We
be
shall be truthful to ourselves and to others.
And we shall try to become a better human being.
we shall
We
try.
should try to
become a better
become a
human
better human being.
Oh God, bless us.
Oh God
God
bless.
bless us.
Daljit, is this coffee being offered to us also?
Sir, why not? Why not? Sir?
Let's start.
So good morning, everyone, and I again welcome you all in this upgraded NHG 6 session. And for this session, the topic would be share what must be shared in neonatology, insights, innovation, and practical wisdom from the NICU. The order of sequence would be first, the HIMS team would be presenting, followed by Little Ferns, then Graphic Era, SGPGI, Wadia, and then AIMS Bilaspur. As we all know, the format has been changed. Now there will be 2 sessions per month, and 3 institutes will be presenting on each day, so that every institute gets around 15 to 20 minutes for the presentation. But today we'll be going with 6 presentations on this day. So I'll request everyone to please take to 10 minutes so that we can complete the presentation by 9:15 after the discussion. So I'll request the HIMS team to please take over, and I will invite Dr. Yashashvi Dhiman, who is Associate Professor in Department of Transfusion Medicine in our institute. She will be discussing about the SDP. Dr. Yashashvi, please take over.
A very good morning. Thank you for inviting me, and it's so good to see Giri sir, Deorari sir, and Daljit sir. Everyone has been associated with us at some point in time. So thank you very much, and I'll just quickly begin with my presentation. So what we have, just give me a minute. So please let me know if the screen is visible.
Yes, ma'am.
Okay. I myself has been introduced by Dr. Chinmay. I'm working as Associate Professor in the Department of Transfusion Medicine, and I'll be sharing some insights from our novel technique that we have just started in our neonates, that is split volume reduced single donor apheresis platelets. We are rather working on it. So we call it the Neo-VRS SDAP. So needless to say, we all are aware that platelet transfusion in neonates is given below a specific threshold, which is less than 25,000 per microliter in a non-bleeding preterm or a term neonate, which is expected to increase the platelet count by 50,000 to 1 lakh per microliter. Now, this increase is basically achieved by transfusing 10 ml per kg of platelets, which is an established dose, which some of you might not know that, it provides around 10 to the power 9 platelets in this amount of platelet volume. And in all, mostly in the centers in India, we are using whole blood derived random donor platelets, which are usually transfused, and 10 ml of RDP should contain a minimum of 7 to 10 into 10 raised to power 9 platelets. So how did we get the 7 to 10 into 10 raised to power 9? So we follow a certain quality control criteria in which a product has to fulfill that criteria of minimum in a whole blood derived platelet. It should be more than 35 to the 10 raised to power 9 platelets in that entire unit. Whereas in an apheresis derived platelet, it should contain more than 300 into 10 raised to power 9 platelets in that entire unit, which is eventually split into small parts for our neonatal and pediatric population. So what we did, we attempted to modify this apheresis platelets to suit our neonates to provide the same amount of platelet volume, same number of platelet volume rather, in a smaller, same number of platelets in a smaller volume, which is 100 ml. So we'll just take it in further slides. So just to give you a quick overview, differences between a adult SDAP product and a random donor whole blood derived platelet. Usually one is collected from apheresis and the other is collected from from whole blood. This usually has a single donor exposure. It has a larger volume, so multiple split products can be given without increasing the exposure to a pediatric or neonatal population. Whereas we have a lesser volume, so multiple donor exposure is there. This lesser exposure helps in prevention of alloimmunization. The volume is more in SDAP, although it is associated with a higher cost, and the increments expected are higher as far as an adult is concerned. One very big advantage of our apheresis product is it is leukodepleted, as it has an inline leuko filter which removes all the WBCs, and then we get the product. Whereas our whole blood derived platelets, it is usually not 100% leukoreduced, or it also may not be leukoreduced at all. So what did we do? In our protocol, we usually have a platelet apheresis protocol set in all the centers all over India, but we just changed it a little. We basically changed the protocol, and we made sure that the quality control criteria is fulfilled. These are the steps that you can see on your screen, which you usually perform on the machine. Finally, what we got was, we changed the setting to 100 ml product is collected, and the platelet number that we get in 100 ml is similar to the adult product. The quality control was maintained. That is, the platelet yield that we got, we made sure that it is more than equal to 215 to 10 raised to power 9 platelets. The pH was more than 6, which is one of the quality control criteria, which is important for our platelet products. It was a sterile and swelling was present, and the volume was 110 plus minus 10 ml, which is around 100 ml, which we are expecting. Now, this is a volume depleted split single donor apheresis platelet modified for our neonatal population, and we split this product into 3 parts using a sterile connected device so that, we make sure about the sterility. So what is the rationale? As we just discussed in the previous slide, one SDAP contains more than 310 raised to power 9 in that entire volume. One whole blood derived platelet contains more than 35 to 10 raised to power 9 in 50 to 70 ml, and our Neo-VRS SDAP platelet has more than equal to 215 to 10 raised to power 9. So when we reduce it, like simple mathematics, when we split these products into 10 ml or 20 ml products, we are giving 25 into 10 raised to power 9 platelets compared to 7 into 10 raised to power 9 from the RDAP, and 15 into 10 raised to power 9 from an adult SDAP. So basically, we are giving 1.5 times more platelets in that 10 ml volume compared to an RDP, and 3 times more number of platelets in that new product compared to our SDAP adult product. So moving forward, we had applied for this patent application in around March last year, and we are happy to share that we have got the application published now in the month of March. We also published a case series for the same, because once we published, we tried using this in our neonatal population where RDPs were being used, but there was no increment in our kids. So this is a list of 30 neonates in which we planned these, which we transfused the split product after they were refractory to SDAP. So as you can see, they were all cases of early onset sepsis. They were a mixed population of terms and preterms. And these were the days the RDPs were transfused, but they were not showing any desired increment as we were expecting. Then we counseled the patient's attendants to get an SDAP done under this protocol. And then these SDAPs were transfused for these on like day 27th, 28th, 31, and 34, the split products from the 100 ml product that we had prepared. So as we can see, these were the results that we obtained. The mean transfused dose was 70 into 10 raised to power 9 platelets. Median platelet increment was 64,500 per microliter versus what we were getting in the RDPs. So this was statistically significant, although it was a small volume. So we were just seeing what results we were getting as far as this case series of 13 cases was concerned. The platelet recovery was 7.5% to 52.5%. And what usually after transfusions, we expect a recovery of platelet recovery of more than 30%. And the split products reduced donor exposure definitely, because initially that same baby was getting RDPs, multiple donors were exposed, but when then eventually we shifted to this SDAP product, then one donor was sufficient and multiple products were given at like around 3 to 5 occasions. The survival was 62% without any transfusion, no adverse events were noted. So eventually, just to make our study more effective and to, actually see how the differences are seen, we have now given this as a thesis topic as a RCT, where we are comparing our product, that is NeoVRS, split volume reduced single donor apheresis platelet. We are comparing it with a random donor platelet in neonatal thrombocytopenia, preterm neonates. And this has been done in collaboration with the Department of Neonatology and under the leadership of Dr. Derari and Dr. Chinmay and Dr. Sagar Patra, who is the co-guide in the thesis given to the patient. So we are basically assigning these products randomly, and then we are seeing the comparison. So far, we have received the ethical committee's approval, and we have started with the thesis. And so far, my first neonate has been enrolled, and the second is underway. I think recently in the past week, the second neonate was also enrolled. So thank you all. That is from my end. I'll be happy to answer any questions. I'll stop sharing my screen.
Thank you so much. The next presentation is from Little Ferns. Till then, if there are any doubts or any discussion, we can please take them.
I think I'll just firstly congratulate Himalayan on an excellent job you are starting with the research. You told that it is leukodepleted. Huh?
Yes,
Correct?
sir. Yes, sir.
That's a
Yes,
very
sir.
good thing. Are you also irradiating them?
No, sir, not yet.
Are you planning to? Are you planning to?
Sir, we can radiate as long as the request is coming from the neonatology department. We can always irradiate. We have a facility, so we can get it irradiated.
I hope the neonatology department would request for it. Chinmay?
Haji, sir, the only issue is cost.
Cost.
It's very expensive.
There is sitting there, he would look at the cost, he would facilitate the newborn care. Okay, thank you.
Thank you, sir.
Now I'll request Little Ferns team to please take over.
You can move forward to the next institute. You can present.
I think there's some technical issue from their team. Request graphic area team to please take over till then. Till that it is solved.
Good morning, everyone. Am I audible?
Good morning. Yes, please go
So good morning, everyone. Today I am going to talk about neonatal hypoxic ischemic encephalopathy. As we all know, that nearly 1.5 to 2 million neonates suffer from HI in India only. The global incidence is much more, and even less than 5% neonates get therapeutic hypothermia, which is the, as of now, only clinical proven modality which reduces the mortality and morbidity in these neonates. So I am going to talk about Giri Cortex. It is an interactive HI education module developed by our very own Dr. Girish Gupta sir. It has 6 core domains and divided into 29 sections. So as I have to complete it in just 10 minutes, so I will not tell you all the details regarding this, but I will tell you some highlights, how it can be very helpful for us. So first of all, it tells about the section first tells about the definition and incidence. Now I can show you how it is helpful for us. In case of term neonates, what are the injury patterns? And in preterm neonates, what are the injury patterns? As you can see on the screen, in the term neonates, the injury pattern is more, if the injury is acute and profound, it is the basal ganglia and thalamus are affected. If it is partial and prolonged insult, the parasagittal watershed area are more commonly affected. Similarly, in the pathophysiology part, it brilliantly tells us about how therapeutic hypothermia acts as only on the critical window. As you can see on the screen, trigger event will be perinatal asphyxia caused by any sentinel event leading to primary energy failure, leading to excitotoxicity. And then after 1 hour, the reperfusion starts, in which we can start the therapeutic hypothermia. It is the therapeutic window which can actually decrease the morbidity and mortality in these neonates. Now, when we deal any neonate with encephalopathy, it should not be only in our mind that HI is the cause of neonatal encephalopathy. There are various other reasons. Differentials we should always rule out, like ischemic strokes, inborn error of metabolism, hypoglycemic encephalopathy, infections, some structural brain anomalies, pyridoxine-dependent epilepsies, congenital hypothyroidism, bilirubin encephalopathy, and so on. Now I will slightly brush upon the acute management part. As it is an interactive module, it tells us about, we can also check the eligibility, what are the neonates who can get benefited from the therapeutic hypothermia, who are eligible, who are not eligible. And it tells about the Sernard staging also. In the investigation parts, it brilliantly tells us what are the investigation need to be done acutely, and at what time, which in neuroimaging, and what kind of MRI modality will help us. At what time should we do it? Supposedly, we are doing diffusion weighted imaging, it should be done at 2 to 5 days. Otherwise, pseudo normalization can be found after that. Similarly, MRS. Now I will take you through the therapeutics part. Now we have an eligibility checker developed in the module only. So as you can see, if I click all these boxes, supposedly all these criteria are met, I can check the eligibility. So as you could have seen on the screen, all the criteria are met and therapeutic hypothermia is indicated. If I click 1 or 2, then again I will check the eligibility and it will show that 1 or more exclusion criteria is present and hypothermia is not indicated. Then hypothermia protocol is well described. What should be our target core temperature? How should we monitor the temperature? How should we rewarm? What are the monitoring should be done during the cooling? And what are the contraindications? Now it tells about the adjunct therapies also: melatonin, erythropoietin, human milk, xenon, mesenchymal stem cells, and other supportive care bundles. Now, seizure burden. It tells about the treatment algorithm, what all drugs should we use. Now I will take you to the neurology part, and it brilliantly tells about the imaging timeline, when to image and why, and what are the MRI injury patterns that can be found. As we can see on the screen, if the insult is acute and profound and severe, basal ganglia thalamus will be affected. If it is a catastrophic event, total or near total pattern will be seen. We have embedded the lactate N-acetyl aspartate ratio calculator also. We can calculate this. Supposedly, I write it 1.2. 2.0. So it tells ki lactate by Na ratio is high and chances of severe adverse outcomes are more. Again, if I change the values, it will tell us. Again, we are calculating, it is still high. So now the lactate Na ratio has become normal. So this calculator also helps us in prognostication also, and what are the long-term neurological outcomes can be in the neonate. Now the MRI request template, what should be sought for? Now I will just briefly touch upon the, as we all know that managing a neonate is just 50 or 60% of the work done. Managing the parents and attendants is also quite a task. So this interactive module talks about the general counseling principles based on the spikes protocol, and also has some examples how should we counsel the parents of neonates affected with HI on day wise and according to the MRI pattern we are seeing. For example, we should explain what happened during delivery, but we should not try to give a definitive diagnosis on the day one. Coming to the day wise, it tells us beautifully about the how should we counsel the parents. Now it also has some frequently asked questions which are asked by parents. And it tells us how should we answer them. For example, will my baby be normal? So we can say that that is the question we are all working towards answering right now. We can tell you that based on these findings, ऐसी probability है. What we know from research that many babies with such conditions do well, especially with the treatment that we are giving. And we should also talk about positive things, that brain is remarkable at recovering, especially in babies. So we are doing our best what we can do as of now. Now I will talk something about our own excellence, what we have created, our innovations in respect to hypoxic ischemic encephalopathy. First one is Girishan protocol. It is a structured bedside protocol for AEG background activity interpretation. It is a tool developed by Professor Dr. Girish Gupta and co-developers are Dr. Shantanu Subham. It is still in a pre-validation phase, but once it is validated, I think it will be very helpful tool. And even with the help of this, we can, it will give us some scores, and even I guess nursing staff will be able to interpret the EEG. So that much effective it is going to be. Next one is Giri Neuroprem bundle. As we all know, the operational guidelines for therapeutic hypothermia applies only to neonates more than 35 to 36 weeks of gestation, but there is a large evidence gap for the neonates less than 35 weeks of gestation. So what to do for them? So for that, we have developed Giri Neuroprem bundle. It is a comprehensive neuroprotection bundle for the preterm brain, which talks about how can we prevent antenatally by various interventions. What are the interventions should we do in the delivery room and after the postnatal period. Another one innovation that our department has created is Encompass protocol. It is enhanced neuromuscular coordination through oromotor, proprioception, and sequential stimulation. It is a oromotor rehabilitation protocol for especially for the neonates suffering from hypoxic ischemic encephalopathy. So they undergo this rehabilitation protocol, and it has been CVI validated, and it is a DRB thesis for our DRB resident also. So how these tools connect to the HI care pathway? On the admission, the eligibility decision can be checked out through this Giri Cortex module. Then during hypothermia, the Giri-Shan protocol will help us during the monitoring of the neuronal function. Then for preterm HI, Giri Neuroprem bundle. For post-cooling oral feeding rehabilitation, Encompass. And in long-term follow-up, we will obviously follow up with the neonates. Now I will just touch upon the few more things. Like it has various calculators, like Thompson score calculator, like seizure burden tracker. For example, we can type in how many minutes, what are the kind of seizures are there. It will tell us what is the seizure burden. Now it will also help us in evaluating our NICU. What percent of the infants were cool. So it is very helpful for us. Coming to the last part, HI, it also talks about the research launchpad. What are the various ideas on which we can work upon, specifically regarding to HI? Like we can study a comparative study of HI outcomes in passively cooled and servo-cooled neonates. Giri-Shan validation study is ongoing. Then HI incidence per se in our hilly areas, Encompass post-feeding. So with this, it also has a self-test which evaluates the learning of the residents who have gone through this module, and it also has AI assistant, and with which you can always ask your questions and it will answer your queries. So I will like to show that this is a citable work which has been published, and you can always find it by using the following links you can see on the screen. So I would like to summarize that it is a very comprehensive interactive module which is easily accessible and can be used thoroughly. So I'm happy to take any questions.
Thank you, Dr. Abhimanyu. I'm pretty sure that this module will be helpful for all the persons working in the NICU. So we are open for the discussion. Till then, I will request the Little Ferns team to please share their presentation.
Sure. I'll do. That's very excellent work, Grace sir, actually. And so I've removed AI slides from my presentation. But it's very nice. And in fact, this thing can be incorporated separately into a app also. Like we tried creating an app also for Little Fun using AI, where all these kind of calculators are there, and this is very excellent use of, I think, the Cloud AI. So bedside clinical decision making tools. In fact, we also started working on similar. Sir, I'll talk to you about this offline. But this is required, like clinical decision making tool. So for a resident, one can enter this kind of tools for each and every model, like for hypoglycemia also, even for bilirubin treatment, for decision making on the antibiotics, decision making on the anadrops. I think sir has already made, and yeah, this HIE, preterm care, all these bundles can be done, and all this actually can be even incorporated into an app, which AI actually can create in 10 minutes. So I think this, so then, that those sections can be really very handy and user friendly for the residents. So great work, sir. Actually, maybe I think we need a separate session for this AI use in neonatology.
Yeah.
So
Thank
I
you,
just have a question for Girish. I'm very sure, is it all done by you, Girish, if done, or you have some AI people and engineering?
Solo, single person's effort.
Acha,
Single.
wonderful. Wonderful. So I think this needs to be widely disseminated among the younger generation, and more people should use it. And if there is any constructive feedback, it should be given to you. I know it is an AI tool, and already this is version 3, which is there. I am very easy. If they give you feedback which is constructive, it can be again incorporated into it. Wonderful innovation.
Thank you, Dr. Ashok.
Okay, I'm sharing. Sakshi has some laptop issues, so I'll share from my end. Sakshi, you've logged in?
Yes, sir.
Okay, I'm just trying to share on my end.
Okay.
So Sakshi is a new addition in our unit. She's done an MD and she's an associate, but she had a good clinical experience. So how we devised this talk as what she felt as a new practices which she had not seen in her practice, and which are value adding and keeping up with the current sort of recommendations. So over to you, Sakshi.
Hi, good morning. I'm Dr. Sakshi, and I've just completed my residency, and I'm currently working as a clinical associate under Dr. Kiran More sir at Little Fun NICU. I've had previous experience in NICU, but my experience at Little Fun NICU has given me an opportunity to learn new and interesting things, which I will be discussing my learning today. Today, we'll be sharing insights, innovation, and practical wisdom from NICU. Firstly, this prenatal interventions overview. This slide provides a high-level summary of 3 major practice-changing prenatal interventions that target respiratory and neurodevelopmental outcomes. Antenatal steroids, now administered as early as 22 to 23 weeks, to improve lung maturity and survival in most immature infants. Total feto trial focuses on congenital diaphragmatic hernia. Fetoscopy tracheal occlusion has shifted survival rates from 15% to approximately 40% in specialized centers. MOMS trial cover in utero repair for meningomyocele. It highlights sustained motor improvements at 2 years and expansion of these surgical centers globally. There is image randomized trial of fetal, so the previous one.
Yeah, that's the next.
Yeah. Delayed cord clamping, the Indian scenario. This slide contrasts the lifestyle trolley UK with the practical application of intact umbilical cord resuscitation in India. This concept is providing resuscitation to a depressed neonate while umbilical cord is still attached. The team dynamics here shows the collaborative efforts required between obstetrician, the staff nurse, and the pediatrician to ensure a seamless transition of blood and oxygen. Here at Little Fun NICU, we maintain this thing and we prepare it previously and we divide the duties accordingly for the proper resuscitation. The Lotus Trolley, it is innovation for developing countries like India. This slide introduces a specialized neonatal resuscitation warmer designed for affordability and flexibility in government and private hospitals. It includes a 180-degree rotating overhead warmer, a low base to slide under the delivery cords, and a phase change material mattress that provides heat without needing electricity. It acts as a one-stop solution for routine delayed cord clamping, resuscitation with intact circulation, and an in-house neonatal transport device. Delivery room CPAP. This slide focuses on early respiratory support for preterms less than 34 weeks of gestation. This highlights the use of TPs and neopuff and the importance of correct size of mask to maintain the proper seal. We ensure at Little Fern that all sizes are available, and we are even using the RAM cannula along with ambu bag and neopuff for providing continuous airway pressure and resuscitating the baby at labor room, and had effectively resuscitated preterms. Now, this is an interesting high-stake clinical case involving 36-weeker born with heart rate of only 30 to 40 beats per minute to a mother who's a known case of SLE. The case was managed with the rapid response of neonatal team. The temporary pacemaker was inserted and was completed within 30 minutes at birth. Baby was born with heart rate of 30 to 40 beats per minute. The echo was done in labor and was immediately shifted to cath lab. The baby effectively survived with the immediate care. Oxygen blending and microflow innovation. This emphasizes the critical concept that oxygen is a drug and must be precisely dosed to avoid toxicity in neonates. The blender here shows a standard air oxygen blender used with mixed gases to a specific FiO2. It shows microflow setup using a Y-piece attachment or a three-way stop clock. This allows clinician to titrate oxygen and air flows manually using the flow meters and a titration chart, providing a cost-effective way to deliver precise oxygen and concentrations in the resource-limited settings. Even though if the setups are who do not have blender, we can do this and make sure that the babies are receiving adequate amount of FiO2. This is indigenous CPAP setup. This slide shows a simple and affordable CPAP system. It is made using basic medical items like an oxygen source, tubing, and water bottle. This system is called bubble CPAP. Using air passes through water and creates bubbles. This bubble generates pressure. The pressure keeps the preterm baby's lung open and helps in breathing. This image shows how system is set up and bubbling works. This practice is still continued in a lot of centers, even in Mumbai, as a makeshift CPAP. Baby pod. This is modern transport incubator. This slide focuses on challenge for transporting newborns in cities like Mumbai. The baby pot is lightweight and portable transport incubator. It is easier to carry than traditional incubators. The pot designed like this, the baby is safe and secure during movement. It also maintains warmth using covered and enclosed space. It makes it useful for safely transferring a sick newborns between hospitals. Nursing homes lifts are usually very small. So we are exploring this type of pods and we have successfully transferred new preterms.
And the twins we are transporting together only. Actually, it's very difficult to transport with two incubators and all those things. So this is actually an image, but we ensure we deliver them in the plastic wrap, the new help, and then we transfer them. So this is now available. Actually, it's a very lightweight. Anyone can lift this pod and can be connected to the syringe pumps and everything. It's very easy, lightweight material, and no electricity or anything required. So can be carried in small lifts, manual lifts, and even can be lifted through the stairs. Only thing that they're still very expensive. We are procuring. We have trialed out the demo, but we are procuring funding if we can get those.
This is the procedure being done here is intercostal drain insertion for a 600-gram baby. The technique here, it utilizes pigtail catheter via Seldinger technique. This significantly lessens the traumatic than traditional trocar insertion, which is vital for the fragile chest wall of an extremely low birth weight infant. Here you can see as we are proceeding ahead with pigtail catheter.
This catheter is still not available. I imported this catheter, and similar PCNL catheters are there, but they don't come up with such a fine, especially for 600 grammer. As you can see, this was very it was just one needle insertion, and this catheter actually is very soft and can be utilized for can be kept for like easily for 5-6 days till the whole pneumo resolutions. It has got 6 holes, so drains effectively, and it's very painless kind of thing to insert. So we are trying to again get it in India. Delivering this is difficult, but we had few catheters, so we have actually done some 4 to 5 babies like this, smaller babies especially with this pigtail catheters. Equivalent version for this is PCNL catheter, the which is cheaper and can be utilized, but they still come up with a larger trocar cannula. And then yeah,
This slide explains the mechanics behind a underwater seal drain used in conjunction with the ICD. The diagram here illustrates the 3-chamber system, the collection bottle coming from the patient end, the water seal to prevent air from re-entering the pleural space, and the suction control bottle. These are the setups which are majorly used and can be made easily available in the all setups. Then
so the idea of putting this was that many times people do put some underwater seal, but many times this proper devices are not available, and many times the practice of putting negative suction is not there because there is no device to connect, or there's interface is not there. So it's always in a tension pneumothorax is always a good idea to have some negative suction, which will facilitate healing. So I think ICD everyone is inserting, but connecting a proper underwater seal and creating a negative suction is also equally important. So if you don't have a proper devices like on the right side, one can actually create through the bottles. Even 3 bottles if you have a pleural effusion and continuously draining the fluid. So that's just a schematic representation of that.
this is successful peritoneal dialysis catheter insertion. Dialysis for a 500-gram baby. In this
Using the
case,
same pigtail. Yeah.
in this case, a chest drain pigtail catheter is used as a peritoneal dialysis catheter. This shows how use of available resources in a smart way to treat kidney failure in newborn. Baby recovered after AKI could be one of the smallest baby recovering with peritoneal dialysis.
So we actually pre-filled the abdomen, and then we inserted the catheter same way like we inserted chest drain. So I've just fast forwarded it. So same again, a guide wire, and then insert this, and very easily with no bleeding. And this catheter actually worked for almost 72 hours effectively with good negative cycles, and where baby came out of the AKI. Very easy to use for the smaller extreme premise. And I think this was in my experience of doing one of the smallest 750 or 800 I had done. This was 520 grams when we did the peritoneal dialysis.
The crashing neonate protocol. It is a new management protocol which we follow here at Little Fun NICU. This slide includes 5-step systematic diagnostic compass for stabilizing a rapidly deteriorating newborn. Focus. The protocol relies heavily on bedside USG across 5 zones. First is lung, identifying the effusions, consolidation, and pneumothorax. Cardiac, checking for contractility, tamponade, or pulmonary hypertension. Cranial, managing intracranial bleed. Abdominal, checking for free fluid or gut ischemia. Central lines, verifying catheter tip placement and checking for thrombosis. This helps us in successfully reviving the babies. Cardiac case, this is the hidden anomaly. The baby was referred from Ulhasnagar. The echo was done by the cardiologist at the periphery, and the baby was being treated as a case of pulmonary hypertension. We received the baby at 6 days of life with a progressive respiratory distress on CPAP and high pulmonary arterial pressure.
So I
The
can just
standard
I can just add in there we as in managing this thing. So again, typical scenario from periphery. Even echo was done by pediatric cardiologist, showing that there is only pulmonary hypertension, and so we actually put the baby on high frequency, and we could get the saturations up to 80s. The SATs were 60 to 70 there, but then on high frequency I could not visualize the veins. I thought it's maybe hyperinflated lungs, and that's why it's not so. But
I still had a suspicion that, something is not quite right in this baby. So we changed temporarily to conventional to get the echo done, and still there was no visualization of the veins. So then I started looking for the trouble, and then we went and put the probe in the abdomen, and there was something unusual shadow was there, which was a kind of abnormal confluence of veins which was entering into the IVC. So this was a infradiaphragmatic TAPVC, and we diagnosed actually 2 cases in this 1 month. So how again, that's why the focus. So whenever we do the echo, we always do quickly abdominal scan, head scan, lung scan. So that's becoming like a protocol that we quickly screen for other organs. So if you can't find out the exact cause, often the the clinical scenario should make sense. If it is not making sense, look for the causes outside the heart. So that was this baby went to Adia, got operated, and now recovering. This still in the hospital right now. So yeah, this is just again, it's not something new, but as a clinical case, innovation that how effectively one should utilize the focus. This is also something similar. Maybe I can take on considering the time. I went. This was referred from Dombivli. Again, was referred as a case of pulmonary hypertension with significant TR, as you can see, and RA and RV dilated. Signs of PPHN were there, and cardiologist has seen this reported as a PPHN. But and management of PPHN was done, and then baby was extubated, but baby failed extubation, and oxygen requirement was only 30-35%. So again, when this kind of scenario was explained to me, and I went, and this was done by the resident there, so it's a very poor quality this thing, but recording. But then when I saw the liver had a basically the liver abdominal ultrasound actually revealed a hemangioma. So, and there were a lot of multiple AV malformations were there. There were 3 large AV malformations were there. So we got this baby transferred to us. We did a CT angio and confirmed those large AV malformations, and that was causing the high output failure. And that's why to manage this, we had to glue those 2 large AV connections, which helped in reducing the cardiac failure. Baby's RA-RV dilatation slowly improved, and baby is extubated and now discharging home today, in fact. So again, the take home here is when you don't find the cause in the heart, please look outside. And same physiology, this is a same physiology which you follow in vein of Galen malformation. So either AV malformation could be in the liver or in the brain or somewhere else. So that's a kind of a take home from the clinical scenario of this month. Next thing, yeah.
This slide reviews technology used to assist in difficult intravenous cannulation. It features specialized vein finders like a V-site or venoscope, and even low-tech but effective use of pulse oximeter probe, red light transsimulation also can be done.
And that's the innovation from Dr. Girish Gupta, sir, which used to use in residency. But yeah, you can see now cold light sources are there, and this kind of modern venoscopes are also available. And yeah, those can be utilized. So I think all the NICU should have this kind of devices for difficult IV access.
Automated control algorithm and accurator. Automated oxygen control, it uses a PID algorithm to process real-time data and accurator to physically turn the FiO2 knob on the blender. This system reduces human error of manual titration. It ensures the baby stays within the target oxygen saturation range more consistently that can be achieved by hand. DR data collection. This slide illustrates a closed loop feedback system for oxygen delivery in the delivery room. A pulse oximeter monitors the baby's SpO2 and heart rate. This data is fed into the PID algorithm on a computer. The algorithm automatically adjusted a motorized air oxygen blender, which changes the FiO2 delivered via TP's resuscitator. Here, the goal is to maintain the precise oxygen level without constant manual adjustment. Automated control example. This slide provides real-world data showing the effectiveness of automated system in 2 different premature infants.
So we are very particular about our oxygen target saturations in the NICU. We have oxygen in one machine, so obviously not possible to do it for all. But we aspire that, suppose this kind of an algorithm can be inserted inside the monitor only, or a monitor with but the backend to the oxygen providing device, then this can reduce the workload, especially in India, because of the nursing ratios are difficult to maintain, especially when the unit gets busy. So to maintain the targets, I think we need this innovation. Unfortunately, it's very expensive. Oxygen, only one SLE we have. Rest all, I think we don't have automated FI to control for. So I think it can be done for even simple oxygen blenders. External device can be created which can control the FiO2.
Kiran, I think
Histogram,
you have to, excuse me,
Yes.
Kiran, you have to close because we are
Yes,
crossed our
running
time
time.
limits.
Okay, we'll stop it. Actually, we are done.
We
Last
have
slide.
another session.
Yes,
Very
yes, yes.
important thing you are doing. We're very
Okay.
worthy. Thank you.
Okay, so I think we'll stop it here. We had something on the artificial one, but we can stop actually. That was the last slide. Thank you.
Thank you, sir. Now I'll request the SGPGI team to please share their presentation. Till then, if you have any comments or doubts, we can always take that for the Little First team.
Good morning, everyone. Are my slides visible?
Yes, ma'am.
Okay. So, very good morning to all the respected seniors, colleagues, and fellow residents. After all the previous marvelous presentations that we have had, today, myself, Dr. Akanksha Verma, Associate Professor from the Department of Neonatology at SGPGI Lucknow, I will be taking you through, continuing with today's theme of sharing what must be shared. I will take you what this has meant for our department. Okay, so let me just begin quickly with a question that probably every neonatologist here must have asked themselves at some point of time. How much of the global neonatal evidence, the landmark trials, the guidelines, or the breakthroughs actually reach the bedside of an Indian NICU, filtered through our context, our resources, our patient population? So there is a gap, and that gap is what made us to think, what can we do about it? Many of you here already may be aware of the Incubator podcast that has been founded by Doctors Benjamin Corsia, Daphna Barbo, and Dean Toms. It's one of the most influential neonatology knowledge platforms in the world right now. So they have weekly discussions on new evidence. There are incredible conversations with the insightful conversations with incredible clinicians and researchers. So it is a truly global community with a global audience. But the question was, where is the Indian voice in this conversation? We have so much to contribute. India, as we all know, contributes significantly to the global neonatal disease burden. Yet most of the data we see there, the content is mostly Western centric. We have our own unique challenges in terms of different disease epidemiology, different resource constraints, the ethical dilemmas that we face, the family dynamics, all of them definitely deserve their own platform. So we thought of not just becoming consumers of the knowledge anymore, and why not just contribute to it as well. So at SGPGI, we thought of stepping up to host this initiative. Hence, after the leadership being taken by Dr. Kirti and faculty from SGPGI, and after a series of lot of online meetings with the creators of the Global Incubator podcast, the Incubator India platform was born in 2024. It is a part of the Global Neonatal Incubator Network, but is dedicated to the Indian neonatal community. And we've been podcasting since 2024, and we release 3 monthly episodes that are available freely on most of the podcast apps. So, talking briefly a bit more about the Incubator India, which is hosted from SGPGI Lucknow. Till now, we have had 6 episodes live, with 4 of them being journal clubs and 2 with guest speakers. So these are the 2 formats that we have had till now. In the journal club, we try to review the latest evidence which is relevant to the Indian context, not just trials, but Indian data, Indian surveys, policy relevant research that can actually, and we try to answer it or interpret in terms of what does it mean to a neonatologist or a pediatrician sitting maybe in Lucknow, Dehradun, Mumbai, India, or any district hospital. And in the guest speaker section, we try to bring on some leaders of neonatology for conversations and for some practical wisdom that we may not be able to get from textbooks. We are truly grateful and proud to say that our first guest speaker on the show was Professor Girish Gupta sir, who agreed to be our privileged guest. And this episode was released on November 30, 2024, wherein sir brought in this conversation, he brought in from his 3 decades enormous experience of early neonatal interventions, starting right from KMC to multisensory integration. So it was a very powerful conversation, some clinical wisdom that we don't really get to see through. And we realized that how much of clinical wisdom actually exists in India that needs to be disseminated and documented through some platforms. So I would urge all of you to definitely go and give back this episode here. Our next speaker on the guest was Professor Shubha Phadke. She is a pioneer in medical genetics. She very recently retired from SGPGI herself. And in this episode, we spoke about the increasingly common role of whole exome sequencing, the genetic counseling, and the ethical dilemmas that we face in the NICU. Again, a conversation with lot of key learning and takeaways for the listeners. Beyond the podcast, we also, as a department, have been trying to contribute across full spectrum of neonatal care, be it stabilization and hemodynamics, respiratory support, infection prevention, neurodevelopment, quality improvement, or innovation and technology. Let me just give you a quick sense of what we've been trying to do. So we have been mostly the work across all the domains is being carried out under the guidance of our faculty by the DM and the fellows and the fellow residents. In resuscitation, we recently had a RCT on the use of wrist versus ear pulse oximetry during resuscitation, which is under review. And this work was actually selected for oral presentation at the 8th annual Neonatal Resuscitation Symposium and was presented at Indianapolis. Apart from that, we have a very proud innovation under Dr. Girish sir of splitting a bubble CPAP, which is a very simple, low resource setting for that can be utilized at the times of crisis. And during COVID, as we were led by none other than Dr. Girish Gupta sir, the necessity led to innovations. A lot of we did at that time, making a low-cost PPE from trash bags, a 3-in-1 face protective gear, and the telemedicine crisis management. So all of these were published and shared, and then we're also trying to bring our neurodevelopmental follow-up data and some QI. At SGPGI, we are using technology by extensively using the point of care ultrasound, and a lot of dissertations and thesis of the previous and the current DM residents is based on functional echocardiography, lung, and cranial ultrasounds. Beyond publications, we're also looking forward at some global collaborations. Dr. Kirti, who is our head, she is leading the India Task Force under the Newborn Brain Society, which is a global society looking at improving the outcomes for the neonates with brain injury. So we have had an unbroken momentum in providing the global research output at this platform. And the vision forward is that we have proposed the establishment of a full working group from India, and it is a formal proposal which is currently under consideration by the Newborn Brain Society Board of Studies, and it envisions to strengthen the neonatal neurocritical care education, the research collaboration and capacity building across the low and middle income countries, and is based on the 4 pillars of educational modules, providing training workshops for hands-on capacity building, multi-centric research by generating collaborative data across LMIC networks, and for standardization of the practices. So let me just quickly share some reflections that we've had from this journey. So you read differently when you have to explain. So preparing, I would say, podcast episodes have actually made us better clinicians and think more so in context of how those studies are relevant to our bedside babies. Indian data is out there but scattered, so every episode actually turns out to be a treasure hunt. The audience is hungry for context. So actually the fellows and pediatricians across the country, they crave for evidence, but it needs to be interpreted for their reality. And finally, sharing is actually not an option, it is a professional responsibility. So moving from podcast to publications to global task forces, the knowledge must keep traveling. We urge you all to listen and subscribe to this podcast app. Moreover, please participate, suggest topics, and nominate guests from your own institutions. It is freely available across most of the podcast apps. And I would just end by saying that the best neonatal site is the one that travels from a journal to a microphone to a bedside. Thank you from the Department of Neonatology at SGPGI. I would be happy to take any questions.
Yeah, this is great actually. I heard a couple of them. Very nice concept actually. You can listen while driving or
Yes, sir. The podcast is actually, most of the people would not sit back to listen it, but they can keep
yeah,
listening to it.
very.
So we try to keep it a little interactive.
Thank you, Dr. Akansha. I'll request the Varia team to please take over.
Am I audible?
Yes, Dr. Nirad, but please change it to the presentation mode.
Okay. Is my slide visible?
Yes.
Okay. Good morning to everyone and all the esteemed faculty members. My name is Dr. Ninad, and I'm currently doing fellowship in neonatology at Vadia Hospital in Mumbai. And I'm going to be speaking a little bit about early intervention and prevention, and about the Hungry Brain Kit that we've devised at our institute. So as we all know, that long stays and exposure to harsh stimuli are known to have a negative impact on the developing neonatal brain. And the goal of any early intervention is to assist infant and family to achieve the greatest potential outcome. And there are broad strategies that aid in minimizing brain damage by various sensory and motor stimuli to achieve this. So what exactly is this Hungry Brain Kit? It's a kit where it's basically a sensory stimulation kit, which can be used for any baby from birth to 6 months of age. And there are, and it's going to help. So there are different kinds of kits over here. We have 11 sets, and each set has a different importance. The first set is which is the starter set. It is for having a clear vision. Then the set 1 builds foundation for logical thinking. The set 2 stimulates detailed observation and builds foundation for critical thinking. Set 3 builds foundation for lateral thinking skill. Set 4 strengthens the photographic memory and enhances concentration skills. Set 5 develops association skills and builds foundation for strategic thinking skills. Set 6 stored words in the form of photographic memory and makes the baby capable to read without any pressure. Set 7 builds the foundation of reading in sentence format. Set 8 develops associative thinking skills and develops love for books. Set 9 enhances the attention span and strengthens bonding with storytelling. Set 10 develops detailed observational capacity and builds foundation divergent thinking skill. And the last set, set 11, flourishes imagination, creativity skills, and deepens passions for reading books. So I'll be explaining. So what exactly are we going to do? So there are 4 different sensory stimuli which we are going to give the babies. First one is the touch, where we'll take a cloth and gently stroke that cloth 10 to 15 times on each hand, palm, arms, and legs for at least 5 minutes. We'll do 10 to 15 strokes and repeat the same with another cloth. So each set basically has 2 cloths and different textures on each side. Then for smell, we have a bottle and we'll be bringing the bottle near to the baby's nose. Wait for 2 to 3 breaths and repeat the same with another bottle. For sound, we'll take the bottle and gently shake the bottle near the right ear and repeat with the left ear. And there's another card which was for visual stimulation. We'll keep the card 8 to 12 inches away from the face at tummy level and say its name and keep for 3 to 5 seconds, and then we'll keep changing the position. As we can see, for different periods of time, we have different sets. So set 1 for 1 to 8 days and set 2 for 9 to 16 days and so on. So the first set has lighter stimuli, and as the days go further, the stimuli increases. So this is the first card that we're going to keep. As we can see in this photo, the card is kept in front of the baby. Distance is 8 inches to 12 inches from baby's face. And whenever the baby is awake, we can keep. What happens when the baby looks at this card? He's staring at the card for 5 to 10 seconds. And we should look if the baby's pupil is expanding and relaxing. The benefit is enhanced clarity in vision. Now, this is the complete set. We can see here set 2 and set 4 are in front of us. The brown and the black paper that we see is the cloth. So this is for the sensory touch stimulation. And the blue and the red bottles we see, these are for smell sensation. So they have different scents inside them. There is a vanilla scent, there are atonia scents. So different scents according to the days of life. Then the white bottles inside have small pebbles which make noise. So that is for the auditory stimulation. So I'm going to be demonstrating a case. So this is a baby of Poonam, born extreme preterm at 27 weeks, extremely low birth weight, 930 grams. Baby immediately cried after birth, has received 1 dose of surfactant for RDS, has grade 1 GMH and ROP zone 1. Currently, the baby is day of life 55, post-menstrual age of 36 plus 1 weeks, and 1.4 kg is on room air and full IFT feeds. Here we can see in the photo, the mother is showing the visual card to the baby. And as we can see, the baby is turning his head towards the card. He's even trying to touch the card. This is a video. We can see the mother demonstrating the touch. And she's talking to the baby as well. So this was the sensation of touch. And this is the mother taking this bottles which have scents in them for the smell stimuli. This is the last one where I was demonstrating the mother how to do it. So usually the mother does it multiple times in a day. We can see the baby is responding. He's looking at me. He's trying to smell the scent from the book. So to conclude, basically, this is just a sensory stimulation kit. It is not going to replace all the other interventions that we do. The main advantage of this kit is it makes mothers and parents in general feel it is more interactive. They are more interactive towards the baby, and they feel like they are also part of the treatment and betterment for the neonate. That is all, sir.
Thank you, Dr. Ninad. Now I'll request the AIMS Blasport team to please take over. Till then, any doubts or any comments you can take for the Bhadia team.
Good morning. Greetings from Bilaspur. We had excellent presentations, new ideas, their implementation from the 5 institutes. In any ecosystem which works and which progresses, there are 3 kinds of practices that happen. Well-established practices which need to be consolidated for a good foundation. Second is new ideas being tried. Some work out, some do not. The ones which work out need to be reinforced. And that is and the some which do not die their own death. And the third set is to integrate these new ideas into the existing system so that the new blends with the whatever is happening in a smooth fashion, and that's how we move forward. We move further, we keep on progressing. I'm sure some of the ideas which have been presented today are in the various stages of getting integrated and will make a difference to the newborn care in times to come. As to AIMS Bilaspur, we are in the stage where things are getting consolidated. So we won't claim that we are, shooting at the stars. We'll just talk of something which has been well established, that how we have implemented, how we have tried to improve the neonatal outcome with that. And for that, I'll request Dr. Nalini, who is the HOD and additional professor of Division of Neonatology at AIMS Bilaspur, to speak. Dr. Nalini, please.
Thank you, sir. Good morning, respected seniors and colleagues. So, as per Dr. Girish's outline, what we are supposed to do, I will be presenting on short slide presentation on these 5 topics. So, the problem here is everywhere we are talking about NICU care interventions. What about community neonatology? So, is it getting neglected? So, I want to emphasize on these 3 delivery room interventions across all levels of healthcare, starting from primary, secondary, and tertiary care. So the few things are delayed cord clamping, early initiation of breastfeeding, and immediate skin-to-skin contact.
Sorry to interrupt, ma'am. Are you also sharing some slide?
Yes, sir. Yes.
It's not visible right now.
Sir, is it visible now?
Yes, ma'am. Now please go ahead.
Slide presentation mode.
So, as per the delivery room interventions are concerned, delayed cord clamping, early initiation of breastfeeding, and immediate skin-to-skin contact across all levels of healthcare, from primary, secondary, and tertiary levels. So, as per the Indian statistics, there is no NFHS 5 data on delayed cord clamping. However, there was a study which is done in 2 states, Gujarat and UP, which has claimed about 95% across all public healthcare facilities on delayed cord clamping. In AIMS Bilaspur, we are at 8.2%, and Himachal data other than AIMS Bilaspur is not available. And the early initiation of breastfeeding, as per the NFHS 5 data, it is 41.8% as against 45.1% in Himachal, and AIMS Bilaspur is 79.4%. And immediate skin-to-skin contact, there are lots of randomized control trials are available in India. To name a few, there are 7 trials which has been included in the recent Cochrane trial. And in AIMS Bilaspur, the immediate skin-to-skin contact rate is at 76.8%. So this is our data over the 1-year period, according for the delayed cord clamping, direct breastfeeding, early initiation, and skin-to-skin contact, with an average of 88.2% for delayed cord clamping and 79.2% for the direct breastfeeding within 1 hour, and skin-to-skin contact of 76.8%. So the insights are we providing quality care? So low cost interventions across all health levels are available, which can be nearly 100% achievable, except in rare occasions. Are we neglecting over core intensive care in tertiary care centers? Implementation of fidelity across the states is difficult. That's what we perceive. And evidence-based intervention is it's been proven. And we have to address this context-specific barriers and facilitate status to improve the quality care. So these are the few evidences which has been Cochrane database systematic review in 2019 article on delayed cord clamping versus early cord clamping, which has been proven interventions regarding mortality and all grades of IVH also. So regarding early initiation of breastfeeding, presently not much of eligible studies are found even in Cochrane review from 2007, as it is ethically impossible to give preferred items, not to give the preferred item, which is standard item, which is a mother's own milk. According to skin-to-skin contact, the recent Cochrane review, which is 2025, which included 69 trials, out of which 7 were Indian studies, and it has also shown that time to initiation of breastfeeding also could be reduced to 48 minutes less compared to the standard care, which is not providing early skin-to-skin contact. So these are the evidences which are shown by Cochrane, and the community health intervention, educational interventions, which have shown that it reduces the mortality without much cost involved in this. So the application is quality improvement studies we should do in the institutional projects to improve the quality of care in our own institutes as per the context specific, and we should include it in as a key performance indicators. This has not been shown anywhere in the national data of NFHS 5 also regarding the delayed cord clamping, or neither it is skin-to-skin contact. So for our own institute and for national data, there should be a key performance indicator which is including this, and departmental audit, monthly audit, and they discuss the way forward. What are the hiccups we are facing for barriers and facilitators regarding these low-cost interventions? And this has to be implemented. Research has to be there from bedside to the bedside. So the take-home message is we have to incorporate these evidence-based low-cost interventions which are already proven. But the one of the key solution is to involve the quality improvement studies and enhance the existing practice at all levels of healthcare. Thank you.
Thank you, ma'am.
Slide share. Stop share.
I think that's final now. Any final comments from anyone?
Thank you from AIMS Bilaspur. It's a pleasure to be part of this August group. It's also a pleasure to see Dr. Devrari, Dr. Girish, Chinmaya, Dr. Kirti, and we have also now new people, Dr. Kiran More and the team and everybody out there at Wadia. And again, our greetings from AIMS Bilaspur as we join this new team, and I'm sure it will be good for us and maybe to you as well. Thank you, Jai Hind.
So I think this has been very educative and informative session, and congratulations to each and every team. I would love that the ECO team does similar type of session for the nurses who are working in the NICU. It may be a Hindi talk they may do, but try to take them together, because neonatology is not possible by only pediatricians or neonatologists or tertiary care running. Nurses need to be all motivated. And the second step would be somehow integrate into the obstetrician also into fold. Let the perinatal concept also disseminate across all the units so that the best practices for newborn can be implemented with a joint effort of obstetrician and nurses. Thank you.
Am I audible?
Yes, sir.
I must compliment every person, every institute, the way today's session has been done. In my personal opinion, is probably one of the best sessions which we ever conducted on NISGI. And I would request my leadership from various institutions to make a remark that such type of a platform which we created today should be continue almost on the same format, which we have also created, or we plan that every time when we are fortnightly, we'll have a one short session, which will be like we have a TED talk on the same platform. We have a neonatal education talk. So this is what the proposal is, and I would solicit that the leadership from the various institutions should make a remark on this today's presentation, and is it all right for future? A quick prompt remark being solicited. Kindly go ahead.
Yes, good morning, everyone. So I think the presentations were all of very high quality today. The only thing we have to keep in mind is the time limit. So because there will be 4 presentations from next month, fortnight, we will be presenting. So the moderation by the moderators should look at the number of slides the resident is presenting, and so that the time limit is not.
Second point taken. Yeah, other institutes, please.
Yeah, sure. And I think, yeah, the time restriction, in fact, we exceeded today, but I think the coordination between the presenters, like today, everyone had some innovative ideas, so it was very unique. But many times we talk on the common topics and there is a lot of overlap. So when multiple institutes are presenting, I think the presenters maybe should meet 1 week prior before they actually finalizing their slides, that they complement each other's presentations and without overlap, and stick to the area which is given to them. Then that will make it more effective.
Kiran,
Go ahead. And technically trialing out the Zoom slide presentation, and that technical issues should not be there, which sometimes delays things. Yeah.
Kiran, point well taken. Chinmay, please take note, and it is for action of all of us.
Yes.
Okay? Yeah, thank you. Anyone else, please?
Good morning, everyone. I would just briefly like to say that it was a truly enriching interinstitutional meet with 6 units. Learn really so much from everyone. Probably proud to be a part of this, and this is actually the strength of Indian neonatal research. Thank you, and thank you for making us to be a part of it.
You can now see.
Yes, Daljit.
Yeah. I just wanted to bring out in response to what Dr. Girish just said, that the standard format should be maintained, and we can keep on trying new ideas each time, a small segment. That would be the way we should go.
Thank you, Daljit. Yeah. Anyone else, please? Bodier? Okay.
So one suggestion, just we can ensure that if we can upload the recording or the presentation, because still we're lacking on that. I'm not sure that we are recording this, so I can request the SGPGI team, because that is coordinating with the eco team. That can somehow be ironed out.
We can work for you. You can have a podcast of artful collection too. Okay.
Correct. I think we should upload. I think we had very high quality.
It will empower you. Okay. And India at large, Yeah. I think that should be all.
Yes, we will do that, sir.
Anyone else, or should we close? Should we go ahead with closure?
So thank you all for this upgraded NHISGI 6 session. I'm pretty sure that from now onwards, our learning experience would be enhanced. So thank you so much.
Thank you, everyone. Have a great day.
Thank you.